We will continue with the more complex. Now we will move to the complex TEVAR. Maybe more options for the complex TEVAR. What do we have and how to approach it? And by Dr. Angsu, Chartrungsan. Dr. Angsu is a cardiac surgeon from Sirat Hospital. Also, our young and experienced cardiac surgeons with a lot of complex procedures that Dr. Angsu has done. So I'm sure that Dr. Angsu may give us some understanding and approach for this difficult situation. Dr. Angsu, please.
Okay, thank you, Dr. Bunpasis and meeting committee, and good morning, everyone. So today I would like to share my experience on how to do some complex TEVAR. So let's start with the case. This is a case with with acute type A dissection in the 54 years old type male and present with a stroke, and the entry tear is quite large at the proximal descending aorta, and he has a very small true lumen with lower body malperfusion with bilateral kidney ischemia when he come to our hospital. So what is the choice of treatment for this kind of patients with type 1 diabetes with a malperfusions? So if you do only hemi-arch replacement, the patient still got the residual type B dissection and the malperfusion will not result. If you select the total arch replacement, in this case, maybe sometimes you face with a very deep distal anastomosis to resect the entry tear. So the good option for this kind of the patients, maybe you perform the hybrid R type 2 with a stage TEVAR or in the same procedures, or you perform the total R frozen elephant trunk. From 2019 European guideline and the last year 2022 guideline from American, the total frozen elephant trunk technique was introduced to treat in the acute type A dissection patients, especially in the case that have the entry tear at the arch or the proximal descending aorta in the class 2 recommendations, or in the case that that is a young patients to prevent the midterm and aneurysmal formations after we treat the type A dissection and to treat the malperfusions. So in this case, I think we should select the total frozen elephant trunk to treat this kind of the patients. And also this technique from the Texas group already present that the hybrid frozen elephant trunk in acute type A dissection does not increase the circulatory arrest time and also can treat the patient with the preoperative malperfusions and have the better short-term survival. And also in the midterm survival in this group of the patient, the total frozen elephant trunk in acute type A dissection have better midterm survival compared to the patient that don't perform the total frozen elephant trunk technique. But there are still some risks of the total frozen elephant trunk, especially in the case of the type A dissection. You will got some risk of the spinal cord ischemia compared to the aneurysm patients. And if you use the longer stent that more than 150 millimeter, there is some risk of the spinal cord ischemia in this group of the patients. So at this time, I would like to show you my strategy to perform the total frozen elephant trunk in the case of the case of the type A dissection. My first strategy is the cannulation strategy. So normally we perform only right axillary artery cannulation to perfuse the brain and also perfuse our body. And in guideline recommend some femoral artery or the direct lumen puncture. But only one perfusion is enough for the malperfusion patients. There is study from the Korean group, Dr. Sukwan Song already showed us, if you perform only one side of the cannulation, right axillary artery, may be not enough. Because if you look at the picture on your right hand side, if you perfuse only right axillary artery, The flow sometimes preference to the false lumen and maybe increase the pressure of the false lumen and maybe compress the false lumen in the visceral area. So the malperfusion may become worsening. So they suggest that if you perfuse both sides, the right axillary artery and also the femoral artery, on the graph they shows in the visceral area the flow measurement in the celiac artery and SMA artery will not decrease. So normally in the case of the acute type A dissection with maybe we suspected of malperfusion, I normally use two arterial cannulation in the right axillary artery and femoral artery. And if you cannot do it, you use the femoral artery, I will select the bilateral, axillary artery, not femoral artery, and cool down to the patient to 28 Celsius. And normally, for the frozen elephant trunk, the stent graft, I use the retrograde or antegrade fashions. So I normally start with puncture percutaneous from the femoral artery, and that you can select which femoral artery can go through the true lumen. And I don't use the fluoroscopic check because normally we can use a transesophageal echocardiogram to confirm we put the pigtail catheter into the true lumen or not. So in this case, I start puncture femoral artery on the right side, and you can insert the pigtail catheter, and then let our anesthetist please check our catheter is go inside the true lumen or not. And then if you have some problem, maybe sometimes you can use flu. After that, you can clamp and then open the ascending aorta. And this is the technique that I use to reapproximate the false lumen and the adventitia and the media. So normally, after you opening the ascending aorta, you have to remove all the clot in the false lumen and clean it with the dry gauze and make the false lumen as dry as you can. After that, you put some the bio glue, maybe minimals, only 3 cc's inside, and then use the endotracheal tube number 6.5 and inflate it around 15 cc's to reapproximate the media and adventitia and wait around 15 seconds. After that, you will see it, the false lumen was gone, and you can trim the ascending aorta as you want to create as a proximal anastomosis. And after that, you finish and you make the circulatory arrest and you insert the stent graft from the femoral artery or anterior fashion any way you want. But in this case, I put the stent graft from the femoral artery. And after that, you land the stent graft at the distal part of the descending at the arch as you want. So normally in the zone 2. And you must land the stent just proximal at the not over of the aortic tissue. And after that, you can anastomose of the distal anastomosis with the surgical graft as the interrupted technique or the running sutures as you choose. But the most important, if you do the running suture, sometimes it can cause the bleeding because if you have the stent graft come out of your anastomosis, sometimes it's very difficult to stop the bleeding. So at this time, I would like to show you, this is how I anastomose the frozen elephant trunk technique. Maybe I will call this is a super secure anastomosis technique because after I use this technique, there is no bleeding of the anastomosis. So I normally start with, I adjust the stent graft the same level at the aorta and start to do the anastomosis with the interrupted phospholine. The pledges what go inside our anastomosis. So normally around 12 stitch of the suture that we use. And every stitch, normally we suture and overlap the previous platelet, and then make anastomosis to the surgical graft that you want. All right, and I suggest to use the surgical graft maybe the same size of your stent graft, or maybe a little bit bigger, 2 millimeter is maybe better, because after that you put the surgical graft to cover your anastomosis. And you just tie down all. With this technique, your surgical graft will cover your anastomosis all around. And after you perfuse, the stent graft will expand, and it can help you to stop the bleeding too with this technique. And also, I use this technique for the proximal anastomosis also at the ascending aorta. As you see that after we perfuse, there is no bleeding from the distal anastomosis. The proximal anastomosis also we use the same. You do the interrupted method, suture over the previous platelet, because sometimes if you tie down the knot, sometimes it can fracture of your anastomosis, but the platelet still inside because it still lock with the previous suture. And yes, after you finish the distal anastomosis, normally I remove the stent graft and start the perfusion from the femoral artery with a 17 or 19 French. You remove the delivery system and you put the femoral arterial cannula instead and start perfusions. And finally, check if you finish all the anastomosis. At the first figure, there is no bleeding from your anastomosis. And you can check your stent graft opening with the transesophageal echo. They can check the false lumen, there is no perfusion, and start to thrombose. And your stent graft is cover your entry site with the axial or the longitudinal segment. They can do it for you. And you can confirm there is a flow only in the true lumen. The false lumen, there is no flow. And the other strategy to prevent the paraplegia in the total fluorescent elephant trunk techniques. So I suggest that use only 100 or 115 millimeter stent graft only. And always keep in mind perfuse left subclavian, because it was a major collateral to your spinal cord. And maintain the lower body perfusion. If sometimes during you do the operation, the patient got some acidosis, you have to recognize there is some malperfusion still in the patient or not. Sometimes you can add on the femoral artery cannulation, it can help. And also, if you perfuse adequate lower body, it has a collateral to your spinal cord also. And always keep the hematocrit of the patient during CPP more than 25%. And if you need to do the circulatory arrest, so I suggest not exceed 1 hour. If you do the circulatory arrest time more, sometimes it can cause the spinal cord ischemia. And if you finish every anastomosis without bleeding, you can keep the blood pressure a little bit high to 120 or 140 to give the adequate spinal cord perfusions. This is my strategy to prevent the paraplegia after the total fluorescent elephant trunk technique. That's all. Thank you for your attention.
Sir, it's a really good case. May I have one question? Because you use one femoral artery as a perfusion and the other groin for the stent delivery, right?
Yeah.
What is your decision thought about, in this case, you said that the patient has malperfusion of both iliac. What is your strategy to choose which one is a perfusion, which one is a stent delivery?
So if there is only one femoral artery you can use, sometimes I can skip to the bilateral axillary artery. If I want to do the total fluorescent left tongue, and if I want to use two cannulation, but if you want to use one side for the TEVAR and one side for the perfusion, so normally I use the size of the TEVAR in the true lumen, and but normally you have to check with your anesthetist every time. You can select to the true lumen both sides, but you have to check with your anesthetist by the transesophageal echo every time when you put the guide wire, when you put the catheter, it's go into the true lumen or not. If it go in true lumen, any side you can use left or right.
You use cut down, right?
Now they normally percutaneous. Percutaneous.
Okay. And for the when you put the stent in the zone 2 or zone 1, so your brain protection strategy is deep plus unilateral, because you already up. How can you perfuse both carotid if your stent is already obstructed the origin?
So normally we use the right axillary artery, one thing, and we have the perfuse catheter. So you cut the carotid and close the proximal part, and you let the catheter, perfusion catheter, go into the carotid and subclavian, anything that you want.
Okay.
Any panels have the questions?
Big question for the super secure anastomosis that you mentioned. You only one layer or two layer?
Only one layer of this kind of technique. So your surgical graft will cover your anastomosis. So normally only one interrupt around anastomosis is enough. So no glue need, no repair, very rare to repair this kind of anastomosis, very rare. But only one thing about this anastomosis to pay attention is maybe sometimes it can cause the anastomosis coarctation, because sometimes you make anastomosis very tight. So sometimes it can cause coarctation. So the only one thing that if you use some small stent like a 26, 24 stent graft, it should be aware about the anastomosis coarctation.
Well, thank you very much, Dr. Angsu. Very nice talk as always.